Hi, I'm Bill Shergy. I'm talking to you from the American College of Rheumatology meeting in San Diego 2017, and just left a very exciting seminar on giant cell arteritis. From the take-home messages from this meeting and this session in particular, giant cell arteritis is really a hot area of interest. We had three great speakers in Drs. Wyand, Carmani, and Grayson, who covered the basic pathophysiology, current treatment recommendations, and imaging studies. These lectures were all superb. Learned some interesting take-home points on the pathogenesis, and one of the really take-home points that I thought about afterwards was that you really are losing privileged sensitivity of the aorta in these giant cell arteritis disorders. And between the combination of increased CD4 cells, leaky portals into the vessels, failure of checkpoints, all lead to the vascular damage. But equally important for the patients in evaluating is what they happen to see in the periphery. And these are diseases, manifestations primarily generated by acute inflammatory products from the liver. And this is the PMR type of features that we've come to recognize. When we move into treatments, certainly steroids have remained the mainstay of treatment, but over the last few months, we've had the first medication actually approved for the treatment of giant cell arteritis in tocilizumab. And this has really become a very important topic. But one interesting area that we've come to see is this seems to focus primarily on the acute phase reactants, the PMR type activity. And even Dr. Wyand was a little uncertain as to what is going to happen long term to vascular manifestations and how closely we're going to need to follow these patients. So it's a great addition to our armamentarium. We can control the disorder, we can minimize steroid use, but we still need to follow the patients, particularly for some vascular complications. And there was some sobering data of patients actually having vascular complications 5 to 10 years out from being disease-free. And lastly, what we're certainly looking for in a diagnostic arena is imaging modalities over an invasive temporal artery biopsy. And we've been real excited about the ultrasound. Some initial reports on ultrasounds really showed sensitivity and specificities in the 60 to 90 kind of range, but other studies have not come up with this. Also, there's MRI and PET scanning, and these two have very variable sensitivities and specificities. But in the certain study that compared biopsy to imaging modalities, it really appeared that the imaging modalities may help more than the biopsy. And there's current suggestion is if you have a firm diagnosis or a very good-looking diagnosis on an imaging study in a classic clinical presentation, then perhaps you can skip the biopsy entirely. If there is a negative ultrasound or other imaging in the setting of a classic clinical history, pursue the biopsy. And if it's a negative imaging and not a classic story, then once again you're free from doing the biopsy. So with that, I will close and say for more information, go to Room Now.